Okay, let's begin. Good evening or good day, everyone. This is Mickey from Wisonic Medical. Welcome to join this global webinar of Wisonic Dandelion College. And this is a platform for sharing and learning more about ultrasound applications to anesthesia, pain management, and intensive care. Today, it is really an honor to invite Dr. YOSI and Dr. Dedi here. So now, let's welcome Mr. Dedi from Sono Medical, the partner of Wisonic Medical in Indonesia. He will give a brief introduction to Dr. Dedi at first.
Good evening, this is Diki from Sono Medica Jaya. Sono Medica Jaya is exclusive distributor.
Diki, I think there is a problem to your voice.
Test.
Yeah.
Hello. Good evening, everyone.
Now
This
it's
is
clearly
from Sono Medica Jaya. Sono Medica Jaya is exclusive distributor of Wisonic in Indonesia. We are focusing on developing, exploring market, including in pain management, women healthcare, and intensive care life support. Tonight, I will introduce Dr. Dedi as will be our moderator for this webinar. Dr. Dedi now is the staff and the lecturer in Anesthesiology Department of University, Airlangga, and Soetomo Academic Hospital. Dr. Dedi is the headmaster of the Fellowship Interventional Pain Management Program of the Indonesia College in private and public hospital, and also lecturer in University Airlangga and Soetomo Academic Hospital. Please welcome Dr. Dedi.
Hello. Hi.
Hello.
Hello.
Yes, we can hear. Yeah.
Okay.
Yeah.
Yes, Dr. Dedi. Can you give a brief introduction to Dr. YOSI and his topic?
Okay, thank you, Mr. Diki. Okay, Assalamualaikum warahmatullahi wabarakatuh. Good evening, everybody. My name is Dedi Susila. Okay, thank you for joining this webinar, which is organized by Wisonic Dandelion College. Until now, there are more than 150 participants are joined. Today, we are going to discuss about ultrasound-guided interventional pain for upper extremity. I think this is an interesting topic because according to the data, a number of patients who visit pain clinic, more than 20% complaining about pain in upper extremity. The location of the pain can be in shoulder, elbow, wrist, and hands. And in daily practice, we often see not only acute pain, but also complaint from chronic pain. Nowadays, using ultrasound for interventional procedure is mandatory because ultrasound is not only to guide when we do the injection procedure, but also help to make a diagnosis such as how to find out the anatomical structure surrounding a pathology area like inflammation, tear, entrapment, impingement, etc. There are so many advantages to use ultrasound as a guided in interventional pain management, but there are some limitations in it, like for deep structure, bone, obese patient. Yeah, I think our speaker can give a trick and tips how to use ultrasound. So to find out more about that, I will invite our speaker to share his experiences using ultrasound. And at the end of this session, we will have discussion. Okay? I'll say hello to our speaker first. Good evening, Dr. YOSI.
Hi, Dedi.
Hey, how are you today?
Yes, fine.
Okay, I heard Jakarta was epicentrum of COVID-19 in Indonesia. Is it correct?
Yeah, but we have survived here.
Yeah, I wish you are in your family in a good and health.
Yeah.
Okay, I want to introduce our speaker. Dr. ROHEDI YOSI ASMARA is anesthesiologist and pain specialist in Tarakan Hospital, Jakarta. He is the founder of Tarakan Pain Clinic, Jakarta, and Director Pain Institute of Indonesia. Dr. YOSI got a certificate fellowship interventional pain management from the Indonesian College of Anesthesiology and Intensive Therapy in 2016. In the same years, Dr. YOSI got certificate FIPP from World Institute of Pain in Hungary and CIPS from BAPMU, USA in 2018. He gives a lecture in local and international pain workshop. He is also the member of Board of Expert Interventional Pain Management of Indonesian College of Anesthesiology and Intensive Therapy. Dr. YOSI, please, your turn.
Okay, thank you, Dr. Dedi. I will start my. Sure, it's already. Okay, thank you. I will talk about the ultrasound guided pain intervention for upper extremity. Okay, first, this is my hospital in Jakarta, Tarakan General Hospital. And this is the outline of my speak today. I will talk about how to do the intervention in shoulder and the elbow area and also in the wrist intervention. At the first, guidance for pain interventions is changing. At the first time, we're using only blind technique, using hand and landmark, just like Daredevil with the blind eyes. And then other guidance are fluoroscopy. Fluoroscopy just like the hook, big guy with string. That but it is have a limitation that it only can see a bone, and the limitation other limitation is it is about the radiation that is produced. And then the last thing right now is ultrasound. Yeah, it's just like Superman eye, that it can see more detail, especially in the area of extremity. It can show more detail about the structure in the upper extremity or lower extremity of the body. So why we using ultrasound for upper extremity procedure for interventional pain? First, most of the case is related to muscle, joint, ligament, and tendon. That's the soft tissue soft tissue structure. And then most of the target are superficial to bone. And then with ultrasound, we can see all the structures. And the important thing is no radiation with the ultrasound. And we can do it the procedure bedside. It's more easy compared to fluoroscopy. This is from the Journal of Clinical Ultrasound about the accuracy of ultrasound guided gleno-humeral injection versus the fluoroscopic guided. It is the study of systemic review of meta-analysis that it said that it has an accuracy of 93% for ultrasound guided and 80% for the fluoroscopic guided for gleno-humeral injection. Okay, I will talk about the shoulder intervention. So it will be the intervention will be AC joint, Subacromion-subdeltoid bursa, and then bicep tendon long head, and Gleno-humeral Joint. Let's see first about the shoulder builder, shoulder anatomy of the shoulder. The shoulder builder is made from the clavicle, the scapula, proximal humerus. And it has the joint. First, the AC joints connected the clavicle with the acromion, and the gleno-humeral joint connected the humeral with the scapula, and then the sternoclavicular joint. And then there's also a ligament there. There's a coracoacromial ligament. This is the important ligament that connect the coracoid process and the acromion process. And then the other is trapezoid ligament and conoid ligament. And also the coracohumeral ligament and transverse humeral ligament that cover the bicipital tendon of long bicep tendon. And the other important thing is the muscle. The superficial muscle of the shoulder is the deltoid, and then long head of the bicep, and the other is a very important muscle. The rotator cuff muscle is consists of supraspinatus muscle, infraspinatus muscle, teres minor, and also from the anterior is subscapular muscle. Okay, I will show you how to do the joint injection for the acromioclavicular. First thing, if you want to do the intervention for the acromioclavicular joint, I usually use the surface anatomy to find out the place where I put my probe before the injection. So usually, I find the clavicle and then follow it to lateral until it meet the acromion. And then, is this the indication of the acromioclavicular joint injection? AC joint arthrosis, AC joint tenderness localized, or post-surgical pain without distal clavicle excision localized to AC joint. Usually the clinical presentation of the problem in the AC joint is tenderness of the AC joint, pain with active elevation of the arm, and then we can test it with a scar test, or we can say the cross arm test. Do like this. We can do the cross arm test, and usually patient feel pain in the AC joint. What equipment that we use is, of course, the high frequency linear array transducer, and then we use the needle with 22 or 25 G needles. And how about the technique? The first one is the position. This is very important. If we want to do intervention, the position of the patient is very important. It can make us easier to do, or can make hard to do if the position is not correct. So the position for the patient, usually I use the sitting, or we can use the supine position. And we trace the clavicle laterally until the acromion process is met. And place the transducer in coronal plane and bring the joint into the view. Okay, I will show it, the video. So first, I will touch this clavicle, find the acromioclavicular, and put the probe coronal to the AC joint. And then we see here that the right one is the medial part, is the clavicle, and then lateral part is acromion. And then we can give an injection with in plane or out of plane. In this picture, it is in out of plane technique. So we put a needle here to push into the joint. or we can do in plane technique from the lateral to medial, from here to here. Okay. This is the picture of that normal joint space of AC joint. Usually, the normal joint space is between 2.5 until 5 millimeter, and the joint capsule bone rim distance is less than 3 millimeter. The second one is how we do the Subacromion-subdeltoid bursa. The Subacromion-subdeltoid bursa lies above the supraspinatus muscle and below the deltoid muscle. If you see in this anatomy, the green one is the bursa of subdeltoid subacromion bursa. Usually, the clinical presentation of bursitis in subacromion-subdeltoid is pain with shoulder abduction or internal rotation. We can test with Neer test or Hawkin test. This is Neer test, and this is the Hawkin test. And then the indication is for bursitis caused by impairment syndrome or rotator cuff tendinitis. Equipment that we use is usually we have to use the linear transducer and with the needle with 25G 1.5 and 2-inch needle. I will show you. This is the picture of the bursa. That's the supraspinatus muscle in below, and above is deltoid, and the bursa is between that, the hypoechoic area that between that. This is how I do the injection. The first, we can do in the normal position of the extremity, or we can do like this in the crouch position. And then I will find the acromion and put the probe slightly, the coronal and slightly oblique to find the muscle. So this is the acromion, and then I'm going more lateral. There's the supraspinatus muscle below, and then the top is the deltoid muscle. So the injection will be in plane from lateral to medial. This is the supraspinatus muscle, and then this is the deltoid muscle. And then the others is long biceps sheath injection. The indication for long bicep is tenosynovitis of the bicep tendon. The clinical presentation usually pain in the anterior shoulder, increase with the active flexion or passive extension of the limb. And usually we can find it in the speed test or Jorgensen test. This is speed test. And then the Jorgensen test for the resisted pronation of the forearm. This is how we scan for the long bicep tendon with a linear probe. We put the probe in the transverse view, and then we try to find the greater tubercle and the lesser tubercle and the groove between them. And this is the long axis view of the bicep tendon, long bicep tendon. This is the structure where the tenosynovitis of the bicep tendon. We see that we can see the bicep tendon here, and then we can see the hyperechoic area. This is the fluid here, and if we see in the long axis view, we can see the bicep tendon here and the fluid around it. The injection technique, a patient supine with the arm supinated, and we use linear transducer, and we do it with transverse or short axis plane with 25G needle. And don't forget that there's a humeral circumflex artery in the lateral part of the groove that we have to do the color Doppler first. This is how we try to find the groove. Usually I palpate it from the lateral part of the head of the humeral to the medial and found the groove. And then I put the probe transverse to it. See here, the ultrasound. See, this is the lateral, this is the lesser tubercle, this is the greater tubercle. And then this is the groove. Inside it is the bicep tendon. And this is the circumflex humeral artery. Yes. So we're going to inject here in the medial part with other plane technique for injection. Or we can do in plane injection, but be careful. We have to do Doppler, color Doppler first, and make sure that your needle is not passed through the blood vessel. And then for Gleno-humeral joint injection. Gleno-humeral joint is a true shoulder joint formed by an articulation between the proximal humeral head and the glenoid cavity. The joint surface area is increased by cartilaginous glenoid labrum. This is the pathology of the gleno-humeral joint. See, this is the gleno-humeral joint, and this is the labrum. Sorry. And this is how we do it. First, put the arm close to the other arm, and then palpate the gleno-humeral, palpate the head of the humeral from lateral to medial, posterior. Find the spine of the scapula and put the probe transverse to it. See it here. I'm going more to medial, posterior, and we see this is the labrum, glenoid labrum, and we put the needle from lateral to medial in plane technique above the joint cartilage. Okay, I will show you. I will try to show you how I do it with a real patient, with a volunteer. Let's see here. Skip. Let's skip this. Okay, and see. Let's see. Okay. So this is how I do the AC joint. First, I palpate the clavicle until it meets the acromion, and then I put my probe, my linear probe, here above it, and we are going to find the joint. So that's the joint. Flesh. Okay. See, this is the joint. This is the clavicle. This is the acromion, and this is the joint capsule here, the dome above it. And then if we want to do the injection, we will do out of plane here from the middle of the joint. how much that you puncture the joint, you just have to pass the joint capsule. You don't have to pass through here because be careful. This is the supraspinatus muscle. Don't puncture too deep, so it can make trouble for you. Unfreeze. Okay. And then the Subacromion-subdeltoid bursa. Actually, after I found the AC joint, and then I go lateral, I will find the acromion. And then in the normal position, I will scan it to the lateral to find the supraspinatus muscle. Okay. So this is the acromion, and then this is the supraspinatus muscle, and this is the deltoid muscle, and the bursa, subacromion and subdeltoid bursa lies between the supraspinatus muscle and the deltoid. So this the black one here is subacromion-subdeltoid. Unfreeze. Okay. And then about the bicipital long bicep tendon, actually I palpate the humeral head, and then I'm going to anterior until I feel the groove in the anterior and put the probe transverse, and sometimes we can make a little bit external rotation of the arm, and then we can found the groove and the bicep tendon. Okay, and color. Okay, that's it. We can see the humeral circumflex artery there. So if you do the injection, we can do it out of plane here. We can do out of plane here, like this, until the needle going past through here. Okay, color hilangin. And then for the gleno-humeral joint, first put the patient hand like this. And then I usually found the spine of the scapula and humeral head, and then I go from lateral to medial. Depth-nya tambahin. Tambahin. Yes, lateral to medial. Okay. And kurang color apa namanya gain kontra ya gain deep tambahin depth-nya tambah lagi. Okay, so I go from the lateral, that's the head of the humeral, so we can see the glenoid labrum here, in the posterior part. We freeze. No. Okay. Freeze. So you can find this is the glenoid labrum. This is the head of the humeral. This is the cartilage of the humeral. We can inject from the lateral to medial to put your needle tip here and inject the medication here. Okay. Unfreeze. Okay. And then we continue with the elbow. The elbow intervention mostly is lateral epicondylitis or tennis elbow, medial epicondylitis, the golfer's elbow, and the entrapment of radial nerve, posterior inferior intraosseous nerve entrapment, and ulnar nerve entrapment at the tunnel. Okay. The lateral epicondylitis or tennis elbow is the problem of tendonitis usually from the common extensor tendon that attach to the lateral epicondylis. The clinical presentation of tennis elbow is usually tenderness over the lateral epicondyle, and we can test it with a Cousin test. This is basically you try to extend your wrist and we try to push back the wrist with force for the extension. This is the picture of tendinosis of the common extensor tendon. We see that there's area of the hypoechoic area. Hypoechoic area here, and here we also see the cortical bone irregularity that usually there's a little tear here above the bone. This is how we scan and do the injection. First, put the patient in a slight flexion in the elbow. Found the lateral epicondyle first, and put the probe with the direction here to the middle part of the wrist, line. So take the probe here and direct it to the middle part of the wrist line. And then, okay, we see here, this is the common extensor tendon. This is the lateral epicondyle. This is where the tendon attached to the lateral epicondyle. This is usually the problem. Most of it is here. Then this is the target of our injection. Usually, if we use the steroid, we do not inject to the muscle. We do not inject to the tendon, but only peritendon. But if you do with the maybe regenerative medication like dextrose or platelet-rich plasma, we can inject directly to the tendon. And then this is for medial epicondylitis. Yeah. This is the medial epicondyle. This is the common flexor tendon. Yeah. We call it the golfer's elbow. Usually the localized tenderness at the medial of epicondyle, and it's getting pain if you do the flexion of the wrist. Exacerbated by pronation, and it may be decreased grip strength because of the pain. We test it with reverse Cousin test. Usually, actually, it's just we do the flexion of the wrist with a resisted flexion of the wrist. This is the picture of the pathology. See the hypoechoic area, and then cortical irregularity in the lateral epicondyle. And then this is how we do the injection. Put the hand like this, slight abduction and flexion, and found first the medial epicondyle, and then put the probe with the direction to the, this is the waistline, and usually I make the middle point of the waistline here for the direction of the probe. So it's going toward to the point here. Okay, this is the ultrasound. This is common flexor tendon. It is attached to the medial epicondyle. This is the medial epicondyle, and then we do the injection here to the tendon. We do it in plane technique. And the other thing is a radial nerve entrapment. The radial nerve in the elbow area, there's a two branch, that superficial branch and deep branch, or we call it the posterior interosseous nerve. This one is mostly, the problem is mostly from the deep branch of the posterior interosseous nerve. You can see here, this is the nerve of the radial nerve in the short axis. This is in the long axis view. I try to scan it from the proximal of the elbow to the distal of the elbow. Okay. So we can see here, this is you can find the two eye. This is the nerve of the radial, and then separated. The superficial are skipped here, and this one is the deep deep branch of the radial. So this is the superficial, this is deep branch. Back, I will try to. Okay. See here, two eye here, two nerve is separated. The deep branch going inside the supinator muscle here. This is the supinator muscle. This is the radial bone. So the deep one is going inside the supinator muscle. That's why usually it gets entrapped here. And we do the injection. I do it with the in plane technique from the lateral to medial. And this is in the long axis view of the nerve. We see the here. You can see that this is the line here when the nerve is coming and going deep to the supinator muscle. This is the place where it's going to inject the patient. And then in the medial part, there's a ulnar nerve entrapment. This is the entrapment between entrapment of ulnar nerve between two heads of the flexor carpi ulnaris muscle. This is the flexor carpi ulnaris muscle. It has a two head. It has two heads here, and this is the nerve, the ulnar nerve, that coming inside the flexor carpi ulnaris muscle. Okay, this is the picture of the short axis and the long axis view of the pathology of the nerve entrapment. You see, this is here. This is the nerve. This is normal here, and then getting bigger here, and then getting normal again here. Usually, the cross-sectional area is more than 9 millimeters. This is how we do it. First, I try to find the lateral epicondyle and the olecranon. Medial epicondyle and olecranon. That's my landmark. And then I put the probe between the lateral epicondyle and olecranon. And then see this is the nerve, and then I track it from proximal to distal, and until it found that this is you see that this is the nerve, and this is the muscle. The muscle belly. This is the head of two heads of flexor carpi ulnaris muscle. See this one? This is the first. This is the second head. So the nerve is entrapped between the two two head of the muscle. I do with the in-plane technique to the perineural area of the ulnar nerve. This is the muscle, and then this is the nerve. Okay, let's see. And I will show you for the patient. That's all. So first, ya, ini datang. Ya, ini ya, ke ini. Okay. First, for tennis elbow injection. First, I will try to found the lateral epicondyle, and then I will put my probe with the direction. You see this one? This is the wrist line. I divide it two in the middle, so this will be my direction for the probe, and I put there. Itunya kurangin, depthnya kurangin. No, dangkalin. Ya betul. Ya terus lagi, dangkal lagi. Oke.
No.
See, okay. Freeze. Okay. So I will see here. This is the lateral epicondyle, and it is joint between the lateral epicondyle, and this is the common extensor tendon. This is the place where you do the injection. Do the injection from here, from distal to proximal in plane technique. Okay, just sit in the needle will going from here straight to here. Okay, and then for the golfer's elbow, put the hand like this. Find first the medial epicondyle, and again, this is the wrist line, and put the middle of the wrist line, and put my probe and freeze. Okay. Depthnya tambahin. Ya, okay. I hope it's clear. Okay, freeze. Yeah, so this is the medial epicondyle. This is the common flexor tendon. Freeze. And then for the entrapment of the radial, first, I will try to track the radial nerve first. Okay, okay. You see, here you can see two eyes of the radial nerve. So the superficial and deep branch. If I follow the deep branch of the radial, it will dive to to the supinator muscle here. Here. You can see here, it's dive to the supinator muscle. I take it to proximal again, it's going up and comes with the superficial branch. And then I take it caudal, distal, it's going to dive to the supinator muscle. And then for the ulnar, with a patient like this is lateral epicondyle, this is the olecranon, and then I put my probe like this, try to find. Okay, boleh lihat gambar yang itu. Jauh. Okay. Okay. So here we can see that's the nerve between the flexor carpi ulnaris. This is in the middle. If you track back, come here. Okay. This is the nerve. This is the flexor carpi ulnaris muscle. Okay. Sudah jatuh. Back to this one. Okay, the wrist intervention, the last part. The carpal tunnel syndrome and the Guyon tunnel syndrome. And also I will show you about the trigger finger. The carpal tunnel syndrome is an entrapment of median nerve at the wrist. Usually, diagnosis of carpal tunnel syndrome now can be made on nerve measurement alone. The nerve measure is a cross-sectional area. Normally, the cross-sectional area of the median nerve in the carpal tunnel area is less than 10 millimeter. If you found the cross-sectional area of the median nerve in the carpal tunnel area is more than 13, it is conclusion that it is a carpal tunnel syndrome. If it's between 11 or 12 millimeter, is inconclusive for carpal tunnel syndrome. This is how we see the pathology of median nerve in the carpal tunnel syndrome. The CIPS is more than, if we measure the CSA is more than 30 millimeter. And then this is the long axis view. See this here? It's more hypoechoic here. This is the anatomy. The carpal tunnel, there's a proximal part and distal part. This is the proximal part between the scapula and fusiform bone, and distal part between the trapezium and the hamate bone. The ultrasound landmark, the polar ridge surface anatomy, put a probe across the distal ridge crease here and palpate for the PC4 bone on ulnar aspect, the ridge crease. And then try to move your thumb, try to move the patient thumb to identify the flexor pollicis longus tendon and then move the second and fourth finger of the patient to identify the flexor digitorum tendons. Median nerve lies under the flexor retinaculum and above the flexor nerve. See the ultrasound video here. I try to move the top. This is the flexor pollicis longus, and move the other finger. This is the flexor digitorum tendon, and this is the flexor retinaculum, and this is the nerve. So, ulang lagi ke belakang. Lagi. We see again. Okay. See, move the flexor, move the thumb. The flexor, this is flexor pollicis longus. Move the 2 and 4 finger. This is a flexor digitorum tendon, and this is the nerve. That's not moving. Okay. And this is the view of normal and severe carpal tunnel. This is in the short axis. This is different. This is a little, and this is a bigger, much bigger. And it's in the long axis. This is normal view, and then this is severe carpal tunnel syndrome. It's swollen. Okay, this is how I scan and how to do the injection. First, find the wrist crest and pisiform bone. Put the probe transverse. Move the thumb to find the flexor pollicis longus. Move the 2 and 4 finger and found the flexor digitorum superficial and profunda. And we will find the nerve here. The Green tunnel syndrome is the entrapment of ulnar nerve at the wrist. This is the ulnar nerve here. How we do the scan here. Back to the wrist crease. Put the probe, just like the same like the carpal tunnel for the carpal tunnel syndrome technique, and try to find this is the area of carpal tunnel, and then above it, above the retinaculum, there's the ulnar artery here, and lateral from it is the ulnar nerve, and we do the in-plane injection from the ulnar part to the radial part. The other thing that most cases I have in my pain clinic is trigger finger. Trigger fingers is a stenosing of tenosynovitis of the flexor digitorum and flexor pollicis longus tendon. This is the tendon. Usually the trigger finger occurs at the first annular pulley. This is we have the pulley here in the this is above the joint of first phalanx to metacarpal. Usually the patient says that he or she has a pain at area of A1 pulley. Sometimes we can palpable a mass or tautness of the flexor tendon. Finger gets stuck when moving from active flexion to extension. So how we scan? Usually we scan in the long axis view here. You see this is the metacarpal head. This is the proximal phalanx. This is the flexor digitorum tendon. And above it, this is the pulley, A1 pulley. Okay, this is the long axis view. And for the short axis view, you can see this is the metacarpal bone. And this is the flexor digitorum superficialis. And this is the flexor digitorum profunda. And that's the tendon sheath here. It's a dome-like here. And this is how I do the injection. In the long axis and in-plane injection, sometimes it's very difficult to do it because of the anatomy of the finger. So usually I do the what we call is I use the gel and the probe just hanging there above the gel. It is to make us easy to see the needle for the injection. This is called the gel stand-off technique. This is for the long axis in plane injection. If we do it in the short axis and out of plane injection, we put the needle in this triangle area between the metacarpal bone, flexor digitorum, and the tendon sheath. So we put here. So back. We will put the needle from here to here, just at the side of the tendon. And then lastly, this is the evidence of ultrasound guided injection in the upper extremity area. We see that most of the research that the accuracy of the ultrasound guided is almost above the 90%. So it's very accurate if we do the injection with the ultrasound. This is the key success. How if we want to do the injection for the musculoskeletal problem, first you have to know the anatomy, and you have to know your weapon, your ultrasound. You have to know how to use your ultrasound, how to set up your ultrasound, and the position of the patient, and also the position of the ultrasound, and also the position of the operator who do the injection. And that practice is make perfect. That's the key success. So you have to practice. The conclusion: the ultrasound has a great accuracy, less radiation, and the anatomy is very important if we want to do the ultrasound guided injection. And the last one, you have to practice, and practice. Thank you.
Okay, good presentation for Dr. Yosi. Applause. Almost 1 hour. You gave the good presentation, and I think so many questions from question from the participants.
Okay.
Until now, there are more than 270 participants are joined in this class. Yeah. Dr. Yosi, are you ready to answer the question from participants? Yeah. Okay. Maybe I will read. Maybe not all, but I think I try to choose. Yeah. Okay. The first question from Ravi Shankar Sharma. What medication you use for tennis elbow, and in what volume? How many cc? Yeah.
Okay. Usually, it depends on the problem of the tennis elbow. Usually, for acute patient is less than 1 month problem, I use the corticosteroid for the injection. I use only 10 or until 20 milligram, and the volume is maybe around 1 until 2 cc, not much, not too much, maybe only 1 cc. But for the chronic tennis elbow, I usually use the regenerative regimen, like I do the prolotherapy using the dextrose. Usually I use 50 until 20% of dextrose, or I will give the intra-tendon injection with platelet-rich plasma. That's for tennis elbow, also for the golfer's elbow.
Okay. For fluorotherapy, how many times you give?
Usually, if I use the dextrose for fluorotherapy, I give the injection around 4 times. The time between the injection is around 2 weeks between one to another injection. Usually the patient after the 3rd injection is getting better. Most of the patient getting better after the 3rd injection. It's around 1.5 months after the injection, right?
Okay. Next question, Dr. Yosi.
Yes.
Okay. For ultrasound acromioclavicular joint injection, does the needle tip penetrate through joint capsule?
Yes. It has to penetrate the joint capsule. Just pass through the joint capsule. Don't push it too deep. That I already talked in my presentation. If you needle going too deep, it will puncture the supraspinatus muscle. It is below the AC joint. So you just put your needle to pass through the joint, the above joint capsule.
Okay. Which is better? Oh no. Which is easier? In plane or out plane technique for AC joint injection?
For AC joint injection, I prefer the out of plane injection.
Yes,
why? Because sometimes the surface of the AC joints is not flat. So sometimes if you put the probe, it's not attached correctly. Or if you want to do the injection with in-plane technique, you try the gel stand-off technique for the injection. I will show you. Okay. I will show you Dr. Dedi. Okay.
Yes.
Gel. Itu lebih fokus ke sini kameranya.
Iya, udah.
Okay. So this is the AC joint. Okay. If you put like this, it's very difficult for me. So I give a gel between it, like this. Give more gel. This is called the gel stand-off technique. Okay. See, I can see the joint here. This is the joint. This is the gel. This is the gel. So my needle can come from the gel. See this my needle. See, you can see my needle. Yeah, just put here. Yeah, and push, puncture the. So if you want to do it in the in-plane technique, use the gel stand-off technique like this. But I usually do the with out-of-plane technique. It's more easier here. I just put here in the middle and put the needle here. Okay.
Okay.
Okay, Dr. Dedi. Yes.
Yeah, thank you. Okay, other question. Dr. Yosi.
Yeah.
Yeah. Do you have any experience in treating subacromial bursitis patient?
Oh yeah. Subacromion-subdeltoid bursa, mostly because of the impairment syndrome of the supraspinatus muscle. So other thing is because the tendinosis of the supraspinatus muscle is very common in the supraspinatus problem. So if you see here, this is the acromion, and I'm going lateral. This is the supraspinatus muscle. Okay. See here, this is the supraspinatus. This is Subacromion-subdeltoid bursa. Usually it's because the impairment of this muscle to the acromion. If you see, if I move the muscle here, up and down, sorry, I will try to move the muscle here. See here, yeah, the muscle is below the acromion. If there is a spur of the acromion, or sometimes a young person after the accident, the space below the acromion is getting more not widened but straight. So usually after before the accident, the muscle can move easily, and then after the accident, it touch the acromion or touch the coracoacromion ligament. Yes, we call it the impairment syndrome. And then after that, the bursa will comes out because of the impairment. That is Dr. Dedi. It's many cases of the subacromion-subdeltoid bursa, many cases in the pain clinic.
Yeah, yes, I often see subacromial bursitis. Yeah, normally we can see bursa. Yeah, but we call bursitis. How many cc maybe? How many wide? Yeah, space of the bursa.
Pardon, Dr. Dedi?
Okay, maybe in the normal patient we can
we cannot see
the bursa.
The bursa,
we can see bursa. Okay.
Yes. In normal patient, we cannot see. Usually, we cannot see the bursa. But in the bursitis patient, we can see it clearly. It is because the bursa is filled by the fluid inside it, so we can see it clearly and separated supraspinatus muscle from the deltoid muscle.
Okay, the next question, Dr. Yosi.
Yes.
Okay, from John Francitepu from Medan. How to diagnose supraspinatus problem using ultrasound? Okay, sometimes in physical examination we diagnose it as a spinatus problem, but nothing found in ultrasound.
Can you repeat it? How we diagnose the supraspinatus?
How to diagnose the supraspinatus problem using ultrasound? Using ultrasound, because sometimes in physical examination we diagnose it as a supraspinatus problem, but nothing found in ultrasound.
Okay. See, the easy way, if we want to see a problem in the maybe left side or right side of the area, usually I compare the problem area with the normal area. So I will scan the supraspinatus muscle. Usually the most problem is in the peak of the supraspinatus tendon here. This is usually the problem. And I will compare it with the normal one. So we can see the difference. Usually in tendonitis patient and in tendonitis patient, if acute patient, we can see first is hypervascularization here in the muscle and tendon. So you can check with the color Doppler to find hypervascularization around the supraspinatus muscle. Other things you will find in a chronic patient with tendonitis of the supraspinatus, it will be a little bit swollen, and hyperechoic. how you can and the other things, if you found here in the bone, this is a normal bone here. If you see, it's smooth. But in the patient with tear of the tendon, you will find the bone irregularity here in the bone. That's one of the signs for tear. For tendonitis, you will find it's a little bit swollen. You can compare to other side of the muscle, and sometimes you can compare the thickness of the deltoid. Usually in the painful area, the deltoid will be shrinking a little bit, if you compare to the normal side, because of the swollen of the supraspinatus tendon in the pain area. That's the answer, Dr. Dedi.
Yeah, sometimes we found calcification in the supraspinatus muscle.
Yeah, right.
And it is very painful if the patient raise the hand. Yeah, I think the good idea compare with the other side, yeah, to found the pathology of the
yes, that's the easiest.
Yeah.
Compare with the normal.
Okay. For Mickey, we have time.
Yeah. Today, really thanks for the sharing and the answers from the Dr. YOSI and the assistant from Dr. Dedi. Especially thanks for all of the audience who stay with us all the time today. For more information about this recorded video and the new webinar of Wisonic, please follow our public account on Facebook or LinkedIn. I think today it's time to say goodbye now. Thanks and see you next time.
Yeah,
goodbye, Dr. Yossi and Dr. Dedi. Have a good night.
Thank you.
Okay, thank you.
Goodbye,
Thank
GK.
you.
Thank you so much, Dr. Dedi.
Thank you.
Bye.
Okay,